Dear all, my name is Luca De Zorzi, and it's a great pleasure for me to present this study about emotional responses in depression according to the visual position of the stimulation. Emotion can be considered as a complex psychophysiological reactions to relevant information, relevant to the adaptation of the individuals, to its preservation or well-being. These reactions impact a set of brain processes and are likely to manifest themselves at behavioral and physiological level. Regarding the visual modality, and if we take this scene, for example, whose resolution has been adapted here to mimic the human visual field, we realize that this visual field can be subdivided into two territories: a central visual field with a good visual acuity and a peripheral visual field whose acuity is lower. As we can see, most of the visual information we are exposed to occurs in peripheral vision. The peripheral vision could thus be considered as an alert system for detecting potentially relevant information, for this information to be focused in central vision and to be identified. In this context, depression is characterized by emotional disturbances such as excessive attention attributed to unpleasant information, or autonomic activation at rest, and hyperreactivity to emotional stimulation. Depression is also associated with attentional disturbances over the visual field, among which deficits in visual orienting or deficits in sustained or executive attention. Those attentional disturbances over the visual field may lead to a reduced attraction by relevant cues when those cues are presented in peripheral vision. Hence, the aim of this study was to compare in depressed patients and healthy controls the behavioral, cerebral, and physiological impact of emotional stimulation presented in central and peripheral vision. As depressed patients are more attracted by unpleasant information or negative events and thought to be less attracted by relevant cues when presented in peripheral vision, we hypothesized that depressed patients will show a better performance when it comes to categorize unpleasant pictures among other pictures, and depressed patients would show a reduced performance and reactivity in response to pictures presented in peripheral vision. The results I'm going to present during this presentation come in part from this article published in Biological Psychology. For this study, we recruited 15 patients with major depressive disorder and 15 healthy control matched patients on gender, age, and years of education. Participants were right-handed French speaker and had normal or corrected to normal vision. We selected two sets of pictures, one set unpleasant and one set neutral, of 175 pictures each. The two sets had the same number of pictures depicting animal, objects, landscape, and human beings. We control the main physical properties of the pictures, such as the luminance, contrast, saturation, so that the pictures only differed in terms of emotional dimensions. These pictures were presented randomly at one of the 5 possible eccentricities, so in central vision at 0 degrees, in near periphery at -12 and +12 degrees, and far periphery at - and +24 degrees. The presentation was divided into 5 blocks, which began with 2 long blocks. The 2 long blocks had a stimulus duration set at 500 milliseconds and an interstimulus interval randomly varying from 10 to 15 seconds, which is an ideal interstimulus interval to analyze autonomic responses. Those 2 long blocks were followed by 3 short blocks with a stimulus duration set at 500 milliseconds and an interstimulus interval randomly varying from 2 to 3 seconds for the analysis of the event-related potentials. Participants had to indicate as quick as possible, thanks to the keypad represented here, if the presented pictures were unpleasant or neutral, and that for all the stimulus for the 5 eccentricities. At behavioral level, we computed the parameters from the signal detection theory, using unpleasant pictures as the signal and the neutral pictures as the noise. The sensitivity parameters in this context indicate the ability to distinguish unpleasant pictures from neutral ones, and the response bias parameters informs about the strategy the participants use to categorize the pictures. A lower response bias in this context indicates a bias towards unpleasant pictures and reflects a more liberal decision criterion with more false alarms and minimizing omission of those unpleasant pictures. We recorded an electroencephalogram, an EEG, and we conducted a spatiotemporal principal component analysis on the event-related potentials. This procedure begins with a special PCA in order to locate the brain responses. This special PCA identifies highly correlated electrodes and reduces them into special factors. Then each special factor was submitted to a temporal PCA in order to identify the latency at which these brain processes, these brain responses are observed. The temporal PCA identifies highly correlated time series and reduces them into temporal factor. At physiological level or autonomic level, we recorded the amplitude of the skin conductance responses, which is an index of emotional intensity or arousal and an index of attentional orientation or attentional focus. We also measure the heart rate variation in response to each stimulation. So typically in response to visual stimulations, the heart rate starts to slow down, which is called the cardiac deceleration, and then increases, which is called a cardiac acceleration. The cardiac deceleration occurs in the context of environmental detection, leading to a sensory intake and indicates an enhanced orienting response, while the subsequent acceleration is a response to the preparation for action and indicates a sensory rejection or a defensive arousal. A repeated measures ANCOVA was applied to the behavioral, physiological, and cerebral variables, with emotion and position as intra-subject factors and the group as inter-subject factors. We control the level of anxiety state and threat thanks to the Spielberger inventory, and pharmacological treatments indicated in depression have been considered and classified using the World Health Organization anatomical therapeutic chemical system and codes distinguishing several types of medication. First, selective serotonin reuptake inhibitors, tricyclic antidepressant, benzodiazepine, other antidepressant, and antipsychotics. The ratio between the prescribed daily dose and the defined daily dose defined by the World Health Organization was used as covariate for the 5 categories of medication. At behavioral level, we observed an opposite categorization strategy between depressed patients and healthy controls. The response bias parameter is represented here according to the eccentricity of the stimulation. So for central vision at 0 degree, for near periphery at 12 degrees, and for far periphery at 24 degrees. I remind you that a low response bias parameter indicates here a bias more towards unpleasant pictures, and while controls represented in blue here showed a response bias toward unpleasant pictures for pictures presented in peripheral vision, depressed patients showed response bias toward unpleasant pictures, but for pictures presented in central vision. Regarding electrophysiological responses and brain responses, the spatial PCA yielded those 9 spatial factors, and here are represented the topographic maps of factor loadings for the select spatial factor. Then each spatial factor was submitted to a temporal PCA, and here it is represented the temporal principal components analysis solution for the first spatial factor, so the SF1. Which was interesting is that the emotion-dependent eccentricity effects in healthy controls and depressed participants, depressed patients, were opposite on the SF1 and TF6 factor combination. So a centrofrontal activity represented here by the first spatial factor, and for early temporal factors which peaks at 102 milliseconds after stimulus were opposite between controls and depressed patients. We therefore observed an opposite pattern between depressed patients and healthy control at cerebral level with this early centrofrontal component identified by the spatiotemporal PCA procedure. And for unpleasant pictures only, controls showed a greater early centrofrontal responses when those unpleasant pictures were presented in peripheral vision relative to those unpleasant pictures presented in central vision, while depressive patients show a greater responses when these unpleasant pictures were presented in central vision. Interestingly, in response to central vision presentation, a greater centrofrontal activity, a greater early centrofrontal activity predicted a lower ability to distinguish unpleasant from neutral pictures. At autonomic level, depressed patients and controls also showed an opposite pattern of reactivity. First, on the cardiac deceleration, for which controls show a greater cardiac deceleration for stimulation presented in peripheral vision, while depressed patients show a greater cardiac deceleration in response to stimulation presented in central vision. And then on the skin conductance responses, for which, unlike controls, depressed patients show greater skin conductance responses to unpleasant pictures when those pictures were presented in central vision. To summarize, we observed that depressed patients showed a response bias towards unpleasantness when unpleasant information are presented in central vision, and a greater early centrofrontal reactivity to unpleasant information presented in central vision. Thus, this data suggests that depressed patients are more sensitive to unpleasant information as far as the central vision is concerned. Our results also show that depressed patients exhibit a greater cardiac deceleration to a stimulation presented in central vision, which indicates an attentional orientation toward any information presented in central vision. But depressed participants also exhibit a greater skin conductance responses to unpleasant pictures presented in central vision, which indicates a greater arousal and greater attentional focus for those stimulations. Thus, patients' attention is preferably oriented in central vision at the expense of any information presented in peripheral vision. Attentional deficits described in depression could correspond to a focus of attentional resources to the central vision, resulting in less exploration of what occurs in peripheral vision. Regarding the emotional reactivity of depressed patients, first, we have shown that this emotional reactivity depends on the stimulated visual space. And we observe that in central vision, depressed patients are more aroused and focused by unpleasant stimuli. These results are consistent with the negative potentiation hypothesis, according to which depressed individuals, have a higher reactivity in response to unpleasant stimuli or negative events. And our results brings in addition a precision by showing the relevance of the negative potentiation hypothesis for the central vision, but not for the peripheral vision. And these results refute the emotional context and sensitivity hypothesis, according to which depressed individuals exhibit less responsiveness to emotions when compared to controls. In conclusion, I would like to emphasize on the fact that this work is an integrated approach to study a psychiatric disorder, approach which seems necessary considering that psychiatric disorders manifest themselves at multiple levels. This study also illustrates that data-driven analysis of event-related brain activity, such as PCA, as presented here, is a valuable tool with pathological samples. Finally, our results should be relevant to understand the mechanisms of emotional disorders in depression and opens new perspectives on other studies using an integrated approach of depression. Thank you all for your attention.
Dear all, I am pleased to present you some of our experimental results concerning attentional bias, autonomic reactivity, and depression, which have been obtained in Scalab Laboratory at the University of Lille. These results focus on the association between attentional bias and physiological reactivity to emotion and their implication in the context of depressive symptoms. It has been shown that relevant information benefits from a privileged attentional process. Among such relevant information, emotional stimuli can grab attentional resources due to their adaptive value. This preferential orientation had been observed for healthy individuals, mostly for the negative information, but also for the positive one. However, the excess of attention dedicated to this information in depression constitutes attentional bias. This type of bias favors attention to certain class of information, like unpleasant ones, or lead to less attention dedicated to pleasant information. This privileged processing of emotional information is mainly subtended by a complex limbic cortical network centered in the amygdala. Such network is activated by emotional stimuli, which in turn activates visual cortical areas and provokes autonomic responses classically associated with the emotions, such electrodermal responses or cardiac variations. In these conditions, an exaggerated visual attention to emotion could lead to disturbed physiological activities, mainly through autonomic dysfunctions. Indeed, literature reports alteration in the autonomic activity in depression, with, however, mixed or contradictory results. For example, some authors report basal hypoactivity in depression concerning cardiac parasympathetic activity, whereas others attest an increase of sympathetic activity as revealed by electrodermal activity. Moreover, some studies also indicate mixed results showing both physiological hypo or hyperresponsiveness to emotion, this depending apparently on the experimental paradigm. All these elements plead in favor of autonomic dysregulation in depression. However, such dysregulation to emotion remains poorly characterized in depressive symptomatology. Finally, and according to some authors, we could consider two main ideas. Firstly, the dysfunctions concerning attentional deployments and autonomic activity are found since the subclinical level of depression. Secondly, for several authors, such dysfunctions could be involved in the emergence of depressive pathology. In view of this data, several strategies have been adopted to try to reduce the symptomatology in this disorder. On the attentional side, there are procedures of attentional training. These allow a reduction of attentional bias, However, the potential autonomic implications have not been evaluated. On the autonomic side, there are biofeedback procedures. These procedures aim to modify the physiological reactivity following a training. They improve the regulation of autonomic responses, especially after the presentation of negative stimuli. However, the potential attentional benefits have not been evaluated. Therefore, it is necessary to take into account both physiological and attentional components of this disorder, in particular because some attentional processes can modulate physiological responses such as electrodermal or cardiac activity. Conversely, physiological responses are likely to influence cognitive processes such as emotional or attentional processes. Based on this observation, the objective of our work is firstly to characterize the association between attentional bias, physiological reactivity, and depressive symptomatology. Secondly, to measure the effect of a modification of attentional deployment on autonomic reactivity. To meet these objectives, a first study was carried out on attentional deployment toward emotional stimuli in visual space. For this study, we used online questionnaires on anxiety and depression with TI and BDI. Based on the results of this questionnaire, we recruited the participants according to different criteria. They had to speak French, be right-handed, not suffer from neurological or visual disturbances, and not use drugs or psycholeptic or psychoanalytic drugs according to the World Health Organization classification. Following the application of these criteria, we selected 34 participants aged 18 to 24. The stimuli used were pairs of emotional images in the right and left hemifield at 12 degrees of eccentricity. We had a total of 16 pairs of unpleasant neutral images, 16 pairs of neutral images, and 60 pairs of pleasant neutral images. We have also controlled the physical parameters so that the images do not differ in terms of luminance, saturation, or contrast, and only differ on emotional content. We presented to our participants emotional pair of images during a free viewing task paradigm. The procedure was as follows. A fixation cross appeared, followed by a number, and participants had to say it in order to control that it looks in the center of the screen. Then, the pair of images were presented to participants, and he could freely explore the images. The procedure was the same with different types of pair. We also used an interval in between stimulation which varied randomly between 9 and 13 seconds to avoid habituation of autonomic signals such as electrodermal activity. During this task, we measured at the behavioral level the eye movements that allow us to obtain indicators of attentional deployment toward the picture presented. We therefore calculated initial fixation to a picture type, the fixation latency, the total fixation time, and the number of fixation for each type of emotional images. At the physiological level, electrodermal activity and cardiac activity were recorded during the task. In addition, we also recorded physiological activities during a 2 minutes of baseline just before the start of the experiment. For the statistical analysis, repeated measures ANOVA were performed on the measurements of eye movements, electrodermal and cardiac activities with the emotion as an intra-subject factor. In accordance with dimensional theory of emotion, valence and arousal effects were calculated using linear and quadratic contrast. For valence effects, we subtracted values obtained for unpleasant condition to values for pleasant condition. And for the arousal effect, we subtracted values from neutral condition to values from emotional conditions, which constitute the average of pleasant and unpleasant condition. Correlation coefficients were calculated between the psychometric, subjective, behavioral and autonomic measures obtained under each of the experimental conditions. Finally, stepwise regressions analyses were performed to determine the relationships between our different variables. Regarding behavioral results, we observed a common pattern for all the indices of eye movements. Here you have the graph representing the percentage of initial fixation, the fixation latency, the total fixation time, and the number of fixation according to each emotional condition. In red for unpleasant images, in gray for neutral images, and in green for pleasant images. For each of the indices, we find a significant quadratic contrast which indicates that we preferentially fix the emotional images, we fix them faster, longer, and in more detail. In addition, no linear contrast is significant, indicating that there is no difference between pleasant and unpleasant images. This result therefore seems to indicate that the participant's attention is preferentially directed and maintained toward emotional images. We also found associations between behavioral and autonomic data. The high frequencies of heart rate variability during baseline were correlated with the duration of fixation toward pleasant images during the task, indicating that individuals with a higher rate of high frequencies in baseline were those who maintained their attention more toward pleasant images. Also, electrodermal activity was associated with depression and with the valence effects on fixation latency during the task. This means that the EDA was higher for the high score of depression, but reduced when the latency of fixation toward the pleasant was faster than for the unpleasant. These results plead for an association between attentional deployment and autonomic activity and reactivity. As the electrodermal activity correlated with depression scores and the valence effects on fixation latency, stepwise linear regression was performed by including depression and fixation latency of the pleasant and unpleasant images that constitute the valence effect in the model. Also, threat anxiety, state anxiety, and age scores were added. After analysis, the model revealed that the BDA and latency of fixation to the pleasant as predictor of the electrodermal reactivity. In the model, the depression score and the latency to fix pleasant pictures contribute significantly to a better prediction of electrodermal activity, while threat anxiety scores contribute only marginally. In conclusion, three main observations emerge from this study. First, it seems that attention is preferentially directed and maintained toward emotional information. This could be explained by the adaptive value of this information, for which the rapid detection and processing of information is crucial in terms of adaptation. We can also think that this is more the dimension of arousal than the valence that favors the deployment of attention toward emotion, since no differences were observed between pleasant and unpleasant images. Second, there appeared to be an association between the deployment of attention and autonomic activity or responsiveness. In particular, a longer duration of fixation on the pleasant is reported when individuals have more high frequency in baseline. In addition, less electrodermal activity responsive are observed when the latency of fixation is faster for the pleasant than for the unpleasant. These results point to an application of physiological activity on the deployment of attention and responsiveness to emotion. They also point to the reciprocal influence of physiological and attentional processes and highlight the need to take these two components into account simultaneously in the study of emotion. Finally, depressive symptoms and attentional orientation predict electrodermal reactivity. A reduction in the orientation to pleasant is found in depression as well as autonomic dysfunctions, In consequences, these results suggest that it may be beneficial to put in place remediation procedures which aim to orient participants toward pleasant information. This procedure may improve attentional deployment, but also have positive repercussions on autonomic activity. In conclusion, the results of this first experimentation show the importance of considering in the study of depression, on one hand, the attentional component and the way in which the attention is directed toward an emotion in a visual space. On the other hand, physiological component, including how the body is affected when studying emotional processing, but also the reciprocal influences between the attentional and physiological components. In terms of perspectives, and this constitutes the continuation of this research project, we are interested in trying to act on the attentional level via the use of attentional training tasks to assess whether repercussions on the physiological level are possible. Indeed, we are currently running an experiment in which we use attentional training to induce attentional deployment toward pleasant information and measure the repercussions on attentional level, but mainly on autonomic level. We hope to find positive repercussions of such procedure on the physiological component, as expected in the light of the result previously exposed. We also hope to present these results to the next Congress. Thank you for your attention.
Hi everybody, and first I would like to thank Professor Sekera for organizing this symposium. Very interesting, and I will try here to show you some data suggesting that it could be interesting to combine a TDCS approach with a mindfulness to treat a resistant depression. I have nothing to declare. Of course, a starting point could be interesting to consider as here when we are facing with a psychiatric diseases, some clinicians can still ask why it could be interesting when we are facing a depressive patient, why it could be interesting to focus on brain data. Of course, if we are facing a question such as can we consider that a mental illness can be reduced to neural brain impairments, this is neuronal reductionism, and of course the response is no. But on the opposite, we are also thinking that when we are facing with a mental disorder, it could be really important to also take into account brain dysfunction. So, of course, psychotherapy is important, of course, medication is important, but we really think that taking into account brain imaging data, brain functions could be interesting to orient the management of these kinds of psychiatric disease. Of course, if we are dealing with such an idea, I'm a neuropsychologist, and the starting idea is that we can apply some kind of neuropsychological concept to psychiatry. And this is mainly linked to the fact that we can try to translate every kind of clinical symptom to a dysfunction of one or more several cognitive processes. For instance, if a patient tell you, when I see a glass of beer, I can't avoid drinking it, you can probably link it to many kinds of psychological dysfunction, but also to a cognitive dysfunction related to a problem of inhibition. Or if a patient tell you, when I walk in the street and look at someone smoking, then I can't stop thinking about tobacco all day long. Of course, this could have many and many psychological origins, but it could also be linked to some kind of cognitive dysfunction, such as attentional engagement or disengagement problem. So here our idea is to try to apply this kind of neurocognitive approach to a major depressive disorder. MDD is one of the most widespread mental disorder around the world, as 350 million of people worldwide are affected by major depression. And it is really important to identify the contributing factors to the development, the maintenance, and the recurrence of this disease. And one of the main important symptoms in these major depressive disorder is an impaired emotional processing, which could be also treated as a sustained negative affect and a persistent reduction in positive affect in these patients. In other words, there are some difficulties in the perception, in the recognition, and more importantly, in the regulation of negative and positive emotions. Of course, this emotional regulation deficit could be linked to a brain inability to appropriately regulate an emotional state. And this kind of dysfunction of this brain dysfunction can generate some kind of specific symptoms, such as, importantly, ruminations. If we have a look to the brain, such kind of dysfunction can be easily understood by the fact that we have an emotional brain, mainly linked to the limbic area, and all these kinds of emotional reaction should be controlled by our cognitive control mechanisms that are mainly located in the prefrontal cortex. However, in these major depressive patients, there is a bad balance between these two mechanisms, and there is a lack of control of these emotional reactions. And this could explain at the neural level the appearance, the maintenance, and the onset of negative symptoms in these patients. Among these symptoms, rumination is a very important symptom in a major depressive patient, as an impaired emotional regulation strategy due to insufficient cognitive control. Ruminations refers to a style of information processing which is defined by the process of recurrent negative thoughts and ideas. So you can't avoid from thinking about negative events. And this is a main causal factor of relapse in depression. So this could be linked then, of course, all to clinical symptoms, to clinical reasons, but also, as I just told you in the introduction of this talk, to some kind of cognitive deficits. It could be attention. You will focus more your attention on all kinds of negative events, and also to memory, as the negative content is always more accessible than the positive ones. Of course, inhibition is really also important in cognitive control and rumination, as effective cognitive inhibition allows people to stop the processing of an activated negative material in working memory and help these people to reorient their attention to other aspects of the situation and maybe something more positive. So, of course, you have a clinical symptom here, negative ruminations, and you can find on these clinical symptoms some kind of inhibitory attentional memory and then cognitive deficit which subtend these kinds of clinical symptoms. So the research question here is, if we boost cognitive control, could this boosting of cognitive control help these major depressive patients to disengage from their negative ruminations and then improve their clinical states? The proposed treatment here is a treatment in which we will combine therapy, psychotherapy, mindfulness-based cognitive therapy, with an approach more devoted to the brain, such as here the TDCS. So the idea here is to apply 20 minutes of TDCS with an active stimulation of the left prefrontal dorsolateral cortex. And this TDCS could be combined with a mindfulness-based cognitive therapy. Of course, the rationale of using these tools is mainly focused on this important paper published by Brunoni, and in which he showed an impact of the TDCS alone in the remission of unipolar versus bipolar depressive disorder, and also on that study of Siegel and collaborators who showed that mindfulness-based cognitive therapy is very important for preventing relapse in major depressive patients. Here you can see the very interesting study of Brunoni and colleagues published in JAMA in 2013, in which he showed that using TDCS in these depressive patients is very effective in depressive patients as compared to sham TDCS. The idea then was to combine active TDCS to mindfulness in these patients. So at the start, our study design was to have some unipolar major depressive disorder resistant to drug treatment. And these patients will be separated in 4 different groups: TDCS or sham TDCS. And the active TDCS group could be combined or with mindfulness-based cognitive therapy, or to relaxation, to have a controlled condition for mindfulness. Due to clinical constraints and to the fact that our PhD student was pregnant, we only performed the TDCS groups for the moment. And then here the idea was to check whether combining mindfulness with TDCS has an advantage on the fact to combine TDCS with relaxation in major depressive patients. So as inclusion criteria, of course, diagnosis of major depressive disorder, comorbidity with anxious disorder was allowed. Patients are aged between 18 and 65, low risk of suicide, treatment as usual, so they can continue their usual treatment, antidepressant and psychotherapy, except for the cognitive behavioral therapy, and pharmacotherapy, antidepressant stable for 6 weeks at least before the beginning of the protocol. As exclusion criteria, we have other diagnoses, neurological conditions, severe somatic pathology, and specific TDCS contraindication, such as metallic plates, of course, in the head. So the idea here was to have between T0, so day 1 and day 10, T1, 8 consecutive days of TDCS, active TDCS, combined with mindfulness, a 20 minutes protocol for 8 consecutive days. And these patients, one group have TDCS with mindfulness, and the other group TDCS with relaxation. And then we also have one remind session after 2 weeks, so as T2. So we have a T0, 8 days of stimulation, then a T1 at day 10, and a T2 2 weeks later. At T0, T1, and T2, we have different tests in order to assess whether the combining TDCS with mindfulness could have an impact on a clinical battery. So we have, of course, BDI and MADRS for depression. We have the SARI test for rumination. We have STAY for anxiety. We also have a cognitive battery. So for the general cognitive functioning, for the working memory, for mental flexibility, and for inhibition. And we also use at T0 and T1 a go-no-go task in using event-related potentials. Unfortunately, this task was still not processed for the moment. So we have here data for patients. In the study I will show you today, we have at the final as a final sample 15 patients in the group TDCS combined with mindfulness, and 16 patients in the group combining TDCS with relaxation. And you can see here that several variables were controlled for at T0, T1, and T2. So of course, we have demographic characteristics with no change, but of course we have the clinical and antidepressant treatment characteristics, so the types of drugs that they take, the clinical scores, which are really important, and we will focus on them now, and some cognitive scores for the different scales. What is really interesting to observe is that we have a general decrease between T0 and T1 for the different clinical variation between T0 and T1. So the clinical states of these patients is better at T1 compared to T0, as for the group with TDCS and mindfulness than for TDCS and relaxation. But what is really important is that for some clinical variation, we can observe that if people show a decrease between T0 and T1 for depression in both groups, we can see that this effect, this positive effect, is still continuing at T2, but only for people who have TDCS combined with mindfulness, while at T2, we observe for patients with relaxation an increase of the clinical state, so an increase of the negative affect in these patients. In other words, we have a decrement of the clinical variable between T0 and T1 for both groups, but the positive effect only continue for the mindfulness group compared to the relaxation group at T2. This is true for the depression scores, but it's also the case for ruminations, for SERI. You can see exactly the same way of the curves. So for the relaxation, a decrease of the rumination between T0 and T1, but 2 weeks later, an increase again of rumination, while in the mindfulness group combined with TDCS, we have a decrease between T0 and T1, but the decrease of rumination continue even 2 weeks after the last impact of the program. This is also the case for the some cognitive tests, as you can see for the digit span, forward and backward. So you see the same kind of increase in between T0 and T1 of the score of this digit span, which is still increasing after the last intervention, 2 weeks later, once this effect disappears in the group relaxation. So we have a general intervention effects. Overall, we have an improvement on every clinical variables. Of course, we can wonder if this is due to a TDCS effect or to a placebo effect, as we have not the opportunity to use a sham TDCS to compare for these results. But we have, nevertheless, some specific effects of the mindfulness, as at the clinical level, depression and rumination still decrease at T2 in respect to what happened for the relaxation group. And this is also the case for some cognitive aspects, such as for short-term memory and working memory. Of course, the question is these kinds of improvement really important for the relapse prevention on these patients? This study, of course, suffers from some limitations. About TDCS, we have some technical specificities of the TDCS, montage, intensity, frequency of the session. These are still things that we have to test in future experiments. As we've done, maybe some montage could be better suited to these kinds of patients. We also could have more longer follow-up of these patients and follow them for more than two weeks, some months later, for instance. And is it specifically related to the fact that patients are resistant to drug medication, or is it a general effect to all kinds of depressive patients? We can't answer to this question. About mindfulness, of course, we can wonder if we can use weekly versus daily mindfulness in these patients, and if it's also the case to use it as well as in stabilized versus acute patient. The main problem of our protocol is that also it is unblinded, and we do not have any sham stimulation for TDCS to control for our results. So the synergic effect is what could happen if we have TDCS during the mindfulness, if possible, because here they have 20 minutes of TDCS and then 20 minutes of mindfulness or of relaxation, but could we do it together? And the experimental mortality was quite high, 15 patients on 36. And moreover, we have some recordings of ERPs, but we can wonder whether this kind of decrement of the clinical variables could also be related to specific neural mechanism, but we can't answer to that question for the moment. So the take-home message from this presentation is that we have, thanks to a combination of TDCS and mindfulness, a general clinical improvement with a specific cognitive improvement and clinical improvement in the mindfulness group compared to the relaxation group. Of course, we can still wonder if this is really feasible in clinical settings, and if this is due could also be due to an effect of the mindfulness alone, as we cannot, if we have not data from a sham TDCS group. So if you would like to have access to more details, this study was already published by Aurore Monard, who was the PhD student involved in that study. And here are some collaborators. Aurore Monard here, or did the study, Charles Conrage, who was the head of our lab, Philippe Fontaine, a psychiatrist, and Marianne van der Hasselt, who is a researcher of the University of Ghent, who is specialized in the use of TDCS. So thanks to all these collaborators for this study and data. If you would have more details or you have some comments, you can send me an email, and I really thank you for your attention.
All right. Good afternoon, everybody. My name is Chris Bagen. I'm a psychiatrist working in Belgium in the University of Ghent, Brussels, and also have some affiliation with the Technical University of Eindhoven in the Netherlands. And for my talk today, I'm going to talk about the use of arterial spin labeling in brain stimulation prediction paradigms. I have nothing to disclose. As most of you probably know, that RTMS, of repetitive transcranial magnetic stimulation, is a non-invasive brain stimulation technique where mostly in psychiatric disorders prefrontal cortical areas are stimulated with excitatory high frequency or inhibitory low frequency TMS protocols. And for depression, it's FDA approved treatment paradigm when you have, or level A in the Lefaucheur guidelines, if you use it in high frequency TMS applied to the left prefrontal cortex, using multiple sessions, meaning that's more than 1 day, daily spread over several weeks. And the efficacy, as we know, is rather modest, but in line with the effect sizes of antidepressant pharmacotherapy interventions. One of the most important clinical questions that we ourselves in brain stimulation research, but of course in other research in depression as well, is how that we can improve response and certainly remission rates for these depressed patients. As we know, the higher the remission rates, the lower the relapse risk, and response or partial response is an issue for relapse, of course. We know already that we have to treat longer at higher intensities, apply more pulses, and the last couple of years, the accurate localization of the stimulated area is of essence. It started in 1985, of course, with Anthony Barker, who proved with here a circular looking coil that by putting one electromagnetic pulse over the motor cortex, giving an axis potential, he could twitch the thumb contralaterally. And this has been the start of a lot of research in neuropsychiatric disorders. How that we do it now is that we stimulate at some point in the motor cortex over here, and we just draw a line 5 centimeters anteriorly to it, and assuming that this target site for TMS is on the dorsolateral prefrontal cortex. But we, of course, we know that the anatomical individual differences do count, and brains are not alike, meaning that for a lot of these patients, we were stimulating not the prefrontal cortex, but rather the premotor cortical areas. So 10 years ago, or a bit longer, I guess, the neuronavigation, or the exact anatomical localization of the dorsolateral prefrontal cortex, was of essence. Here you see it, that you do it in a non-stereotactic way, meaning that you have an MRI scan for a given patient, and then you can localize out of the room, out of the stereotactic use of it, the prefrontal cortical areas. There was a very interesting first study of the group of Paul Fitzgerald in Australia, who divided their depressed sample more or less in two. Half of them had the 5 centimeter rule, was not that accurate, and other 24, the dorsolateral prefrontal cortex was localized with MRI, neuronavigation, and they, as a state of the art at the time, they applied 3 to 4 weeks high frequency TMS, and they found the difference between the standard and the targeted localization, that there was at week 4 some difference in clinical outcome, pointing to a better outcome for the targeted area than for the standard area. But of course, it was a rather limited sample size, and it was for sure not that clear if it was really an effect of the anatomical targeting or not. Anyhow, nowadays, the individualization or the personalization for TMS and depression has been a hot topic, pointing that the individual data to be used in your treatment paradigm could have been of essence. And a large study, of an important study from and from the group of Michael Fox. He showed already in 2012 that the more effective TMS targeted site with the less effective target site, more in the region of the 5 centimeter rule, was negative correlated with the activity in the subgenial ACC. So how more negatively the connection, the better clinical outcome, and these more effective targeted sites were certainly more in theory than before. It's a bit too fast. Let's see. Another avenue of treatment, also using individualized data, is at the level of the TMS itself, about the paradigms, and instead of daily sessions, there is some kind of new avenue going to accelerate TMS, where you're going to apply more sessions a day instead of one session, multiple sessions, and not for a couple of weeks, but only applied over a couple of days, and this is called accelerated TMS. So when we were 10 years back or a bit more, the golden standard was daily sessions over 2 weeks. Now it's a custom that it's at least 3 weeks of one session a day. And there are some studies or research going further, 6 weeks. But then we are coming, of course, to a situation that we are going to daily stimulate patients for months, which is a burden, of course, not only for your patient who is coming to your clinic every day, but also somebody, of course, has to apply it. So the idea was, why don't do it otherwise to increase the response, concentrate everything over a couple of days and intensify your TMS paradigms. This is the study that I'm going to talk about, where we have used that accelerated TMS in a theta burst stimulation fashion, where we have for a session around 1600 pulses, which is the average number of pulses for a daily session, but instead putting it or giving it for once a day, we are doing it 5 times a day for 4 days. We have 20 sessions over 4 days period, and in total patients have around 33,000 pulses. We target the left dorsolateral prefrontal cortex, the anatomical area, with neuronavigation, and patients who have active in the first 4 days of stimulation after the weekend, they receive sham, and those who had sham, we apply vice versa, of course, active in the second week. We have an exact copy of a real and active and a sham coil, mimicking, of course, the visual, but to some part also the sensational effect of the TMS. And as we know that there are some delayed effects with accelerated paradigms, we do measurements also after 2 weeks of stimulation. We are using arterial spin labeling as a measurement. The advantage is, of course, that it's used as an endogenous tracer, that you don't have to use a radioactive agent, for instance, for FDG PET or as an MPO SPECT. It's proven to be a reliable physiological marker for neural activity. You can quantify on a stable regional cerebral blood flow, and it's less variable across subjects. So we assume that it could be a more straightforward way to determine predictive value of the individual target left dorsolateral prefrontal cortex, and importantly, the functional connectivity with the subgenial ACC, as done with resting state functional fMRI. We calculate the interregional covariance functional connectivity between these 2 areas as the outcome measure. On the other hand, we also determine the outcome not as a change of the depression rating scale scores, but we are using response and remission. as the outcome, because we think this is the most meaningful clinical outcome, that a patient who is treatment resistant, at some point of their treatment, they at least experience a response, which is of course a 50% reduction of the baseline Hamilton scores, or a remission, maybe even more importantly, having an end score at some point from the Hamilton less than 7. Of course, non-response, patients do not adhere to one of these criteria at any given time point. So we have a baseline scan, ISL, tailspin labeling. We have response and remission after the first week of 5, 13 after the second week, 17 after the entire part, and overall we have at some point patients that are responsive in remission of 23. It has to be said, of course, that some of these patients after a couple of days they relapsed, but otherwise the other ones they didn't, and we didn't have any sham responders over here. So we calculated that overall patients of 23 that responded one way or another to these interventions. When we were looking at the covariance functional connectivity between the subgenial ACC and the left dorsal prefrontal cortex, this is the region that you see here in green for the subgenial. This is the mean region of the intended stimulation of all of the 41 patients that were included. We also overlapped it with the Yale anatomical atlas to see which kind of prefrontal cortical areas that were stimulated. The most of them were in the default mode network, but what we saw here, and you can already see it here as well, is that the non-responders were localized a little bit more around the anatomical area that was intended, and the non-responders, and the responders, excuse me, they were, let's say, spread a little bit more around. On the other hand, the structural and the functional connectivity between the dorsolateral prefrontal cortex and the subgenial ACC from the responders was significantly stronger than the non-responders. But the physical connection distances, if you see here, there was no significant difference between them. So the stronger the connections between the subgenial and the left, in the individual left stimulated areas in the prefrontal cortex, was predictive for clinical outcome, at least meaning that the individual differences and these functional connectivities are of essence. We also saw, if you were looking at the Euclidean distance for the mean values here, there was significant difference, although mostly falling into in the default mode area. But again, meaning the closer that you are to the predefined structural stimulation area, the weaker the covariance perfusion and the less likely depressed patients were irresponsive in remission. So what does this mean? Is now the neuronavigation or the anatomical localization of importance of or not? The answer here is not that straightforward. First, you have some kind of a quality check now in TMS and certainly in clinical research. If you want to replicate, or even if you want to publish, it's indispensable that you have some kind of orientating or navigation where exactly that you have stimulated your patients. So although in clinical practice is a bit common that the adaptive or the individualized localization of the dorsolateral prefrontal cortex anatomically generates a better response rate, some of the studies are pointing to that, but at least it's not that spectacular and not that convincing. And the most recent studies didn't find any difference in clinical outcome in larger sample studies. So, notwithstanding that it has been postulated that a more correct structural targeting of the dorsolateral prefrontal cortex may be necessary to increase this response rate, our current findings indicate, and we have to admit this is of course a limited study, 41 patients with treatment-resistant depression, where we applied a specific accelerated intermittent theta burst paradigm in an accelerated fashion. When targeting the left dorsolateral prefrontal cortex based on only the structural cortical data only, probably the results will be suboptimal, and there will be some kind of a need of a functional direction or guidance. So, of course, we have the limitation that is only limited to the accelerated ITBS. We have a relatively small sample size, and of course, it's a retrospective study, and we need prospective RCTs, large one, of course, to see if this hypothesis that you need anatomical and functional data together, that is indispensable. There are some studies doing it now. This is one small study, but an important study of the group of Nolan Williams. It has been replicated in a more recent study by Cohen. These open label studies, but these authors, they used the negative or the anti-correlation, the strongest anti-correlation in treatment-resistant depressed patients, and they found by using, of course, another kind of accelerated paradigms where they applied 10 sessions a day for 5 consecutive days, which is nearly triple the number of pulses that we in a very, very severely treatment-resistant group, targeting the anti-correlated area that most of them qualified as responders, and 4 of them were in full remission, which is a very spectacular but very encouraging way to apply accelerated paradigms using individual functional connectivity data. I thank you for your attention, and if questions, please do not hesitate. Thank you.